I think we all knew that doing LAA on a conscious patient, you have air management is super important now. It's even more important than you were in the positive pressure ventilation patients.
All right, so today our special guest is my partner and mentor, Dr. Raghava Gollapudi. He's at the San Diego Cardiac Center, and he really pushed this conscious sedation left atrial appendage occlusion program for us. We had a good bit of difficulty sometimes scheduling cases. There would be delays. It'd be tough to kind of coordinate. So I wanted to kind of go through a little bit about conscious sedation and how to do ICE and how to get started on this as well. So, Raghu, I guess first thing I'll ask you is, who's this program for to do conscious sedation left atrial appendage occlusion?
Okay, I'll first start off with I'm not Arvind's mentor. He's my mentor. He's taught me so much. And without team-based atmosphere, it will never work. If you just have one doc trying to spearhead this thing, it won't work. But to that point, for years, the TE portion of the ICE of a Watchman slash LAAO occlusion was so difficult. You couldn't find a doc. People would run away. The funding mechanism for the TE doc was difficult. And also training the doctor of what you need. You need an interventional echo doc, like you'd find an anesthesiologist. They would help you, but they wouldn't know what you want. And then the cardiologists, they themselves wouldn't be able to guide you at the appropriate steps. So they didn't know what we were doing.
And there's
So
quite a bit of
then
variability with anesthesia, right?
100%, even with a cardiologist,
Mm-hmm.
even within the cardiology realm, you couldn't train the TE doc to do what you wanted them to learn. It took, now if you got fellowship docs, it'd be a different story. But for us, it would be a little different. Like we were by
And Raghu,
ourselves a
your
little bit.
your practice setting is what?
We're in private practice. Now we have some fellows that come, but we are really deal full private practice. We're kind of academic, we try to be, but we're still private practice, and funding becomes important, and also time became very important.
Yeah, it's tough for a clinic doc to run over from clinic if you're 30 minutes behind or a STEMI comes throughout the day.
Right. So then you saw some data that came out of Europe. They had these 100 case series, 100 versus 100 case series of that showed that conscious sedation or ice-based closure with for Watchmen, let's say, was safe. And so we were like, oh man, we need to develop a program similar to this because it is safe. Now we'll talk about it later on, as you'll allude to, but it is a safe procedure and it puts all the work in your hands. So you're able to show the images you want. You're able to do everything and not have to train a new doctor every case. It's like an AI scribe rather than a new scribe that you get every week that you have to train. And I mean
Mhm.
that for the anesthesiologist or the echo doc that comes on the table.
And Raghu, when you do LAAO, you do it solo?
I do, yeah, all solo. Even if there's an anesthesiologist there, I'll still do it solo because in the hospital we work at, they don't provide us with a cardiac-based anesthesiologist to run the TE machine.
Got it. So
So this
I
so
get.
this became a way for us to become predictable for the patient ultimately.
Mhm. So how did you kind of go about this? How long did it take you to get comfortable? What were your eye skills kind of before this?
So my skills were really rudimentary. You know, Arvin, when we would hang out, we would do just ASDs and PFOs. We wouldn't, those are really just 2D echo, 2D imaging. And so it was really simplistic. Now we did mitral clips, et cetera, before all this started, but the ICE you wouldn't use. And then I'd watch the EP docs and ICE, and they would use the ICE for transeptal, and that's all they would use it for. Then they'd rely upon the TE for the final imaging. So then I said, "Oh shoot, I can use the ICE for the transeptal, and then I can get away from the TE doc." I would come over and do the TE initially. This is during anesthesia era. I would do the TE, look at everything. Then I'd come over, rescrub, do the case with ICE only, then do the transeptal, then just use fluoroscopic landmarks, do the put the Watchman in, and then re-image by TE again, unscrub, and then go back and forth.
So you'd unscrub again, kind of like a solo doc.
Correct, because it would be unpredictable to find a TE doc for us.
Gotcha. And so how long did it take? Were you, when you started your program, did you do this with both? Did you do TE only, where they intubated still, or did you kind of go right into it?
So I would say it took 20 cases really overall, and we would do both. We would let the patient, would intubate the patient, put the T probe down, then use ice. Now, yes, financially, that's a loss to the hospital system. So you have to kind of get some gain. We would use at that time, we'd only use a 2D ice catheter, and we didn't have the 3D ice or 4D ice catheter yet, but we'd only use that one at that time. It worked. It worked adequately. It wasn't perfect, but it worked. And I'd say 20 cases, but like you alluded to, we would do both. Then we started doing conscious sedation with an anesthesiologist a little bit, and we would run, and I would drop the TE probe at the start of the case, and then I'd drop the TE probe afterwards. The anesthesiologist would get mad at me a little bit because they'd say, "Oh, why are you dropping the TE probe twice?" And so it became a little bit of a logistical problem with them. But eventually, I just became comfortable with just ice only. And yes, I do. And we'll talk about when I do the TEE.
Got it. So how do you determine who's a candidate for this?
So you're going to see this screen that one of the nurses at where we work came up with, and it's actually a wonderful tool. I think the nursing staff have to be on board for this because they can make your life difficult. So I would say if the nursing staff's on board with you, these are the kind of absolute contraindications. Really poor LV function, unable to lie flat for a long time, just some language barriers were one of the things. A lot of alcohol use, patients who had a high pain tolerance. Now, relative ones, and this has probably become more important as some more data has come out. Bad sleep apnea, morbid obesity. I'll do that again. Bad morbid obesity, um, bad sleep apnea. That's a really bad one now in the conscious sedation era.
With
If
the
you have a
snort.
lot of obstructive sleep apnea, we're cautious now.
Mhm.
And difficult with prior cath and a lot of pain addictions.
Got it. Yeah, this is nice. I mean, do you ever use this or think about this for other cases,
I
complex
do.
coronaries or something like that? It's
Yeah,
a nice little screening tool to kind of
and
think about.
because
Mhm.
anesthesiologists make it comfortable for you. Honestly,
Mhm.
it
Yeah.
takes away one element of difficulty. Like I don't do these like you do, like these CTO interventions. Like sometimes you guys are on the table for a long time, and
Yeah.
it takes away one element of the the procedure, so you're not as stressed on one other aspect of the procedure.
Yeah, so this is our LAO screening tool. The nurses kind of call the patient ahead of time and before, and we can kind of show this and save this screen. But it kind of highlights what Raghu was talking about: the sleep apnea, risk factors, old age, their history, looking at their cardiac function. But overall, it kind of just looks at should we have BiPAP on standby when we do our conscious sedation LAO. So here's my kind of take on the ICE step by step. I know Regu and I do this a little bit differently when we do LAO solo operator. For me, I'm a true planner. I personally like the true plan. I like to get a CAT scan. I kind of get a sense of the lay of the land. Um, I do like this for multiple reasons. One is because you can potentially see screen failures. Very few patients are screen failures nowadays, but you kind of get a shape of their left atrial appendage, the size of it, and it kind of predicts also your transeptal technique, which I kind of like. And you can also kind of think about if a case is going to be really hard, challenging. For me, it helps me visualize how the watchman is going to sit. If maybe I'm going to have to leave a little bit of a shoulder or something like that, or maybe have a device a little bit more out than I would need. But I kind of like this because in my brain it helps me kind of visualize it. So um, so when I do the transeptal again, like Raghu was talking about earlier, I really didn't have much skill set into this. Most of my training was done with TEE. So I think in ICE, the important thing really is to make sure you know where you are. And that's finding your basic views. So if you're looking at your home view, your right atrium, right ventricle, and tricuspid, that's kind of your home view. And then I kind of visualize all the cardiac structures. So if you clock a little bit from there, clock your ICE catheter, you'll start seeing the aortic valve come into view. Keep clocking a little more and you'll start seeing the septum. From there, you kind of give it a little bit of posterior tilt. And I think one of the things when I was starting is doing things one at a time to understand how motion of the ICE catheter or a clock or counter of the little wheels will move your image is really important. So when you're just starting with ICE, I do like that a lot of saying, okay, this is where I am, this is what I see, to get my image to move, this way, maybe push the catheter in and things will get centered, or move the catheter back and things will get centered. So I kind of like to try to find the LAA and the pulmonary vein to kind of get a sense of where I am in terms of anterior versus posterior here. And when we're doing transeptal, this is kind of the superior side, this is the inferior side. And then what you're looking for basically is daylight on the other side, and then you can kind of cross safely at that point. So I think this is probably the hardest part of the procedure. Raghu, I thought that this was a little bit more challenging, and sometimes this could be the barrier of adoption, I feel. Crossing the actual septum with the ICE catheter. The way I do it is you use the 17 French Watchman sheath, make a hole in the septum, and then I make sure I unlock the device. I kind of flex the device anterior and I try to follow the wire. For me, I kind of do this fluoroscopically. I give myself a 3-minute timer. If I'm not able to do it with a 3-minute timer, at that point, I will steer across using the wire as a marker. Basically really keeping the wire in view right at the tip of the ICE catheter and using fluoro at the same time to cross the septum. Raghu, what do you think of this technique? I thought this was the hardest part, learning.
No, I agree, Arvin. I think, and it's also the frustrating part. If you're trying to do an ICE-only case and you got the patient conscious, and if you can't drive that ICE catheter across, then you're like, damn, what am I going to do now? How am I going to safely deploy this device? Especially if you don't have pre-imaging, then you're really not in a good scene. So I like the same thing, Arvin. I do the same exact way. I try to integrate like the wire on the sometimes I try to be like an EP doc. EP docs tell me they do this all fluoroless. I'm not that good yet. So I do both, but I try to use the ICE catheter. If you go really inferior, like you'll see, you know this, but if you try to go, if your stick is inferior, I try to find the ICE catheter on the screen. You try to find it right in front of you. Then I drop down maybe 2 or 3 millimeters, and I go a little anterior flex with whichever device you're using. And there's 3 devices, as you know, in the market. Whichever one of those 3 you use, I try to come down a little bit, and then go anterior, and then try to cross. Sometimes it works, sometimes it doesn't. Now the big one, but it in general works. And I try to use fluoroscopic, and I try, just like you said, the 3-minute rule, and then don't give up. I think almost always you're going to cross.
Yeah, I can only think of one time maybe I couldn't cross the septum, and that had more probably to do with the location of the flex on the ICE catheter and the way the vein was kind of steering me. I just couldn't get the angle to fit.
Right.
I feel like when I was learning, I felt like one is making a big size hole. So the larger sheath is actually a little bit more helpful. I fluoro store where I make my transeptal just to kind of have a sense of that. And then a lot of times the entry point across the septum is you start lower than you think, because when you're messing around too high, you just kind of keep missing the dilated hole in the septum. And then I like to go across with an unlocked device, making sure it's a little bit more comfortable so you can kind of steer and kind of have a feel for it that way. But I thought this was definitely the hardest part, and I think this is probably the biggest barrier of entry to conscious sedation or ICE-only Watchman program.
I know some people do 2 sticks. I probably don't. I'm not saying that's wrong. You can do that too. Some people do.
Yeah, I guess if you're really in a bind and you couldn't cross, maybe that's the second step, right?
Right.
But yeah, usually for the most part, I can get across within the 3-minute timer that I give myself.
Right. I agree.
So again, I think for us, we kind of just we're working with a few different docs that kind of help train us. They proctored some cases with us, but this I like to call this view kind of like the LA home view, where you have the left atrium, the mitral valve, and the LV. That kind of helps you get oriented. That way you can kind of just see where everything is. And typically for this image, you may need to advance your ICE catheter a little bit and clock a little bit to see the left atrial appendage here. But kind of the step-by-step, this always got confusing because we were so used to saying 0, 45, 90, and 135 for Watchman. But I think this, we're kind of calling it almost like a mid-angle view. Mid-angle view, this one is kind of like almost like a hybrid a little bit. It's not really pure aortic valve, not really mitral valve, but I kind of look and like to see the left atrium, the mitral valve, and the LV. You push forward, clock a little bit, and then slightly posterior tilt, and usually that can bring the left atrial appendage in view. And I think when we were doing our 2D ICE only, it would be sometimes difficult to get all three great views. I thought I could probably get 2 views pretty good, and then 1 would be really difficult. So the 4D ICE has actually made it way easier, that you can kind of get 2 good images and kind of take your tech and go 45 degrees from that, which made it, I felt, a lot easier and a lot more confident knowing how your device was sitting. Here's the low angle view. The low angle view, here's the aortic valve in place. So this is usually counter till you see the aortic valve, and then you kind of put some slight right-sided tilt on the ICE catheter, and usually then you'll see the left atrial appendage that way. So that's kind of how I've been getting this low angle view, and typically this is kind of our 0 to 45 degree view. This is similar to kind of our 45 degree view where everything kind of looks nice. I feel like this is kind of the same view, but it is helpful to assess position if something is too far in or too far out. And this is kind of the high angle view, or a view looking from the mitral valve, kind of our 90 to 135 view. Basically, to get this view, you keep that right-sided tilt on if you find your aortic valve. You tilt a little posterior and you counter, then that ICE catheter will drop and it'll be kind of looking from the mitral valve up at the left atrial appendage. So your ICE catheter is actually underneath and you're looking at the left atrial appendage that way. This is kind of a super helpful view when we do LAAO. I do like this a lot because it kind of confirms leak and things like that. So it is super helpful. So sometimes if I can't get a great view with my 4D ICE catheter, I will just do a dedicated view of this. And at times things can get a little stiff in there with your catheter across, and then you have your ICE catheter across. Things sometimes don't bend as well as you would like. So sometimes it's a little more challenging to get this view in that setting. But here's kind of a step-by-step case that we have. So first thing I do is I start kind of like almost like a home view here, and we'll do like a multi-view and just assess if there's any effusion. After that, we'll do our transeptal and then get the ICE catheter across. And timing-wise, once I get my ICE catheter across, I will get one really good image of the left atrial appendage. So after that, I am able to kind of store our images with the reps. Then I'll drive my sheath across. Right now, my sheath's hanging out in the right atrium. After that, things may move a little bit, but at that point, once I'm kind of getting set, getting everything into the left atrial appendage, the reps can kind of measure and confirm everything that I do with the CT. Is this the right size, right device? By that time, they'll get me 3 measurements. We'll also have our CAT scan ready to go. And then at that point, I'll have an image of the left atrial appendage with fluoroscopy and contrast, and then we'll have basically 3 different ways to essentially get this. Now, Raghu, you do this a little different, correct?
I do, yeah. For me, what I do is I drive first I don't have a CT, so I do a TE on the table. But we have the pediatric 3D TE probe. That's been a godsend. Mm-hmm. And so it's a baby probe. It works really well. And then I personally, my goal is to get the ICE across the septum. So I will do the transeptal just like you're alluding to, drive the sheath across the delivery system, and then pull it back. Then get the ICE catheter across the septum, and then I'll push my sheath back across. I just want to get the sheath and the ICE catheter across. That's my only first goal. Then the next goal is to try to find myself in space.
Hmm.
And because I did the TE on the table, the measurements that I find from the ICE catheter are not as important. So then I'll actually drive the sheath with the pigtail in front of me into the appendage, and then I can figure out where the lay of the land is. It's like a marker on the ICE catheter. So it's easy for me to find where the device is. Sometimes I still have a hard time getting lost in space. And so I personally like that. But like you're doing, I think that's wonderful. I think it's both
And
ways
you
work
remove the
equally as well.
TE probe. You do the double dip then.
Yes, I take a bit, but I've dominantly used this pediatric 3D TE probe. We've got both vendors at the hospital now,
Hmm.
both the GE and the Philips. And pediatric 3D TE probe has been a godsend, honestly. We actually used it for a mitral clip the other day, for a patient who couldn't do an intubation. So it's been really, really nice,
Oh, that's nice.
for that. Yeah.
Yeah, so then after that, we'll kind of, you see there's no ET tube, no TE probe down. So we have kind of the ice looking, almost from the mitral view, looking at the Watchman device. And, I found any kind of appendage, any anatomy, not really a contraindication for this technique. You start doing a bunch of cases and you get pretty comfortable with it. And again, fluoroscopy on top of ICE is there, and then because we have the Echotex, TE is still potentially an option that you can always do, because we do TE without anesthesia all the time, just conscious sedation, fentanyl, and Versed anyway.
Yeah, I think that's right, Arvid. And
Mhm.
that is one of the things that, because as the cardiologist, we do the TEs, as the interventional cardiologist, we do the TEs without an anesthesiologist available. So dropping the TE probe one last time to reconfirm any uncertainty. But I like how you did on that prior screen, how you do you still use an angiogram to use your eyes with that as well. That's
Yeah,
really
just
important, I think.
another set of eyes. Yeah, and this is kind of just a view of the low angle view, and then how you can kind of go 45 degrees off and get multiple views in this. And I think just kind of repetition, just like anything else that we do, is super important. But this is able to kind of show you're able to get measurements, look for leak, look for color, and I don't think the image quality is really degraded with this, and honestly, I felt pretty comfortable releasing a lot of these. So, and very few times do I drop a TE probe on top of it. And usually in that case, it's just a really challenging, difficult appendage in those scenarios.
I agree, Arvid.
Mhm.
Same.
So,
It's a great case.
I guess, Raghu, for you, um, there's a FDA warning now about the sheath. Does this kind of inhibit you from doing these cases? What are you looking out for? What are you watching out for? What's your technique to kind of combat this?
So I think it's important. I think we all knew that doing LAA on a conscious patient, you have air management is super important now. It's even more important than you were in the positive pressure ventilation patients. So I've always said, be careful. Watch for them to obstruct their airway. Watch for them to have these episodes of apnea, and don't open that TUI. Don't open that the hemostatic valve when that happens. So I'm trying to make sure, and I try not to oversedate the patient for that reason. I try to hydrate the daylights out of them. If their LA pressure is 10, definitely give them 500 bolus of saline, a liter bolus of saline while you're working, to really tank them up so you can get the left atrial pressure higher than the RA pressure, and then use those techniques of keeping the sheath low. But I'm really watching how they're breathing as well while I'm doing my case, so that whenever I open that hemostatic valve, that I'm cautious that the patient is not taking a deep breath at that same moment. And so those are the kind of things that I'm really, really cautious with. So therefore, when we were talking about that prior slide, really bad sleep apnea will probably give me a little bit more fear now for that.
So that may tip you to doing anesthesia-based case.
Correct.
Mhm.
Correct.
Okay.
I
So
think that's when air entry is really where we find it.
So in summary, then is kind of hydrate, lighter sedation,
Mm.
and sheath management of not lifting your sheath too high or moving it in the wrong direction.
And only opening this hemostatic valve for a second at a time.
Hmm.
Don't just like let that thing bleed back, watching everything bleed,
I
and
see.
then the
Okay.
patient takes a huge deep breath while you have that hemostatic valve open.
So you're
You
really
get
quick with that maneuver. Got it.
correct,
Hmm.
correct. I'm like very very fast with that.
All
Those
right.
are the I watch those things, and sometimes I don't do an angiogram on the table,
Hmm.
uh, just so I don't introduce any more air. I'm using ice a lot, etc. So yeah,
No, wonderful. Awesome. Well, thank you so much. Thank you, Regu, for your
thanks a
time.
lot,
We
Arvind.
appreciate it. Yeah, and
Thank
thanks
you.
for pushing this forward. So the next step is conscious sedation TAVR for you, right?
For
Nurse-led conscious
conscious.
sedation TAVR.
Oh yeah, well, we want to be like Emory.
Yeah, so nurse-led
Yeah,
conscious sedation TAVR is the
we
next
want.
phase
Well, maybe one day we'll get MitraClip. I'm just joking.
of this.
We
All
do
right.
nurse led. I do conscious sedation TMVRs.
Yo, yeah, that's true.
Same thing, same version.
All right. Thanks, Regu.
Alrighty, guys.
Appreciate it. All
Thanks,
right.
man.